Hello, my name is Lakhmir Chawla, and I am delighted to be giving you a talk on the use of non-catecholamine vasopressors in the treatment of vasodilatory shock. So, Louis, I apologize that I couldn't come all the way to London to give this talk, but per your request, hopefully this is something that some of your staff and fellows and trainees will get something out of. So, before I get going into some of the content, let me first give some key disclosures, the first of which is that I'm a professor of medicine and was previously at the George Washington University Hospital of Medicine in Washington, D.C. for about 20 years, but I'm now the Chief Medical Officer of La Jolla Pharmaceutical Company, which is the company that makes Angiotensin II. And I think that more importantly, I think it's important to recognize that I am the most conflicted human on planet Earth for Angiotensin II because I've been working with the molecule for around a decade now, since 2009. And I think the reason why this is so important is because as you go on in your career, people will disclose their financial conflicts as a routine. It's part of our culture now. But a larger conflict is that when you want something to work, when you've been working with an asset, when you have a hypothesis, that's a place where it can create blind spots. And so I think that people should keep that in mind as they look at the data. With that in mind, I will endeavor to give you a very scientific talk. And I think that one of the first big questions that routinely comes up is simply this question: why do we need another vasopressor? Arguably, catecholamines and vasopressin have been enough. For those of you who are in the younger category, for people like myself and Louis, when we were in our training, we didn't use vasopressin at all. The only debate that we had is which catecholamine do you use? Was it dopamine versus epinephrine versus norepinephrine? And we spent a lot of time discussing oxygen transport. The use of vasopressin as a vasopressor in conjunction with catecholamines is relatively new and arguably is a mid-2000 event. And the reason for this is that high-dose vasopressin had been demonstrated to be quite toxic. But this notion of lower dose vasopressin has been brought back, and of course, this is something that's part of your clinical practice right now. The reason why, among the reasons why it made sense to me that we may need another vasopressor is because it's in your body. So whether you believe in God or evolution, depending on your spiritual preference, these things are in our body, and they are in our body for a reason. And they work together, they work synergistically. If evolution decided that you only needed one vasopressor, you would only have one vasopressor in your body. But there are multiple vasopressors. They're deployed differentially to vasoconstrict different vascular beds in order to modulate the flow of blood to different tissues. So it made sense that if the number one selling antihypertensive in the world, which is an ACE inhibitor, it made sense that angiotensin II has a role. And this comes from a very strong multi-mode bias that I have. Now, if you look at a disease like HIV, we had many drugs that decreased viral load, but it wasn't until we put them together that we began to get an effect. And arguably, the silver bullets in modern medicine are gone. There's no longer, sort of penicillin, and it's the only antibiotic. Everything is sensitive to it. Those days are gone. If you look at hepatitis C, it's not one antiviral drug, it's combination therapy. And then a lot of people say, yeah, MINK, that's all fine, well and good, but those are infectious diseases. Well, what about cancer? If you have lymphoma, you're getting CHOP, MOP, HOP, CADOP, some goofy combination that I learned in medical school and totally forgot about. You're getting some stick it in my eramab with, a steroid and vincristine and some other combination I don't understand. Cancer is not treated with single therapy. And people say, well, yeah, that's fine, MINK, but that's cancer. Okay, let's take other things. In pain management, I trust that you are not adding fentanyl to morphine. And when you're taking care of patients with seizure management, I trust you're not adding lorazepam to diazepam. But more apropos, perhaps, is an inflammatory disease. We can agree that sepsis, most vasodilatory shock, is from an infectious cause, inflammatory cause. Rheumatoid arthritis is an inflammatory disease. It is not treated with a monoclonal antibody to IL-1 or TNF-alpha alone. You're not just on Humira or Enbrel, you're on that plus methotrexate, plus a steroid. It's always combination therapy. That is what works. So if other inflammatory diseases are using combination therapy, why are we so fixated on single mode therapy? But I think the best example is hypertension. So I want you to think about your clinical practice and your training and all those clinic visits before you were in the ICU, and thinking about all those patients who walked in who had just simply mundane, therapies related to hypertension. Were any of those patients receiving 9 grams of labetalol? And if you had a patient who was receiving 9 grams of labetalol, would you add metoprolol to that patient to control their blood pressure? I think not. But everyone listening to this, I want you to ask yourself this question. How many times have you added epinephrine to norepinephrine? How many times have you added dopamine to epinephrine and norepinephrine? We do it all the time. And why is this? Why are we doing this? Do we really think we're going to find the one alpha receptor in the amygdala that we haven't gotten with, 0.1 and 100 mics per minute of NORAD? Right? I mean, this doesn't make any sense. And I think more to the point is the fact that all these catecholamines are essentially the same drug. So I always make my fellows revisit the catecholamine metabolism that you all learned in your first year of medical school. And I insist that they refer to dopamine as pre-proepinephrine because dopamine is metabolized into norepinephrine, or for those of you in the UK, noradrenaline, affectionately referred to in the shortened form of NORAD, which in America is the North American Air Defense Network, so it's kind of amusing to hear it spoken that way all the time. That's neither here nor there. And then proepinephrine, which is norepinephrine, is then converted to epinephrine. So I am quite amused when my fellows come to me and say, hey, MINK, we're on a lot of norepinephrine right now. We think we should add epinephrine. I'm like, oh, do you think there's a problem with the body's ability to convert the norepinephrine to epinephrine? And they say, what are you talking about? And I said, it gets converted from norepi to epi. So we are just adding more of the same drug over and over and over again, and we are stunned that we don't get a good result. I would argue this is the definition of insanity. So let's just start with some basic tenets before we dive into some data. Fundamentally, all of these vasopressors, noradrenaline, adrenaline, dopamine, vasopressin, all of these drugs were available in the 1950s and 60s. And since then, if you look at all the trials done, there has never been a trial that has demonstrated superiority of one vasopressor over another vasopressor in any trial. This is the Cochrane Review 2016. Dopamine versus norepinephrine. It's close, has not made it. That was SOAP2 data. Phenylephrine, terlipressin, vasopressin. This doesn't even include the VANISH data. There is no vasopressor that has ever been shown to be better than another one. So what that fundamentally means is that when you reach into your toolbox and you reach for a vasopressor, whichever flavor of vasopressor you want, you are reaching for MAP, and you are paying for MAP. And that is why you are picking a vasopressor. You're not getting a vasopressor to get survival benefit. You have failed fluids, you are reaching back for MAP. So you're paying for MAP. The question is does it make sense to give single mode therapy or to give multi-mode therapy? And I will not bludgeon you because everyone listening to this who is familiar or works in ICU knows the data. The VAST trial, which was conducted and published in February 2008, showed no survival benefit for vasopressin versus norepinephrine. This is the more recent VANISH data. And I think what's interesting about this study done by Tony Gordon is that they actually used vasopressin as first-line therapy, and they allowed the dose to go up to 0.06 units per minute as opposed to the standard 0.04. And what they found in this trial, which I think is interesting, is that the survival trend line that we observed in VANISH was inverted, and patients who got vasopressin actually had a worse survival. This was not statistically significant, and arguably this is the same number. But the point here is that the trend line reversed. And some people have suggested this may be because of the ability to up-titrate from the 0.04 to the 0.06. And I don't think we will actually ever know the truth of this, because I think this is a subtle signal. But there's a reason why this might be the case. So if you look at one of the early papers, and this is Intensive Care Medicine 2001, Jim Russell's group was looking to ascertain the dose for vasopressin for the VAST trial. So they did a study of vasopressin hemodynamics and renal function in severe septic shock. And this was the study which came before VAST and helped inform the dosing of VAST. This is the study where the 0.04 units per minute comes from. And what they did is they essentially looked at patients and they looked at the dose. And what they said here is that there were 6 cardiac arrests in patients who were receiving vasopressin infusion, and all the patients in severe refractory shock. One patient had a marked decrease in vasopressin, a cardiac index on vasopressin infusion of 0.03. And what they concluded is that, and this is up top here, is that the patients who had cardiac arrest tended to be the ones who had a dose above this 0.03, 0.04 range. And that's why they selected this. And it's basically noted here, which is that the dosage of vasopressin at the time of cardiac arrest were more than 0.03 units and up to 0.6, which is a lot of vasopressin. And because of this, because there were no cardiac arrests reported below this 0.03, 0.04 threshold, this is the rationale for why they selected this dose. This was the point where they thought they had the best safety range. And VANISH went above that slightly. And so some have suggested this may be why that trend line was reversed. I don't think that we will know that, and hopefully there'll be an analysis in the future looking at patients who were kept below 0.04 and 0.06 in VANISH, and maybe we can see if there is a threshold amount. I think this is hugely problematic for one reason, and one reason alone, at the bare minimum, which is that vasopressin is not dose weight-based. So 0.04 units per minute in a 45-year-old kilo woman is very different than 0.04 units per minute in a 850 kilo person. And so I do think that the lack of weight basing makes this a little bit more complicated. But the take-home point is that vasopressin was a known vasopressor for a very long time. And we went away from it because at high dose it created toxicity. And at lower dose, it's a very good drug. I do think that the 0.04 units per minute is the safe range, and we should be very careful going above that. And I think if you think about vasopressin, we can say that it is the primary non-catecholamine vasopressor that's been available for arguably 40 years. It has shown 0 survival benefit in 2 large randomized controlled trials. And so if you are an academic purist, and if you say that I shall not ever use a drug in my clinical practice that has not demonstrated a survival benefit, then I commend you on your academic purity, and I'm absolutely certain that you never use vasopressin because you now have class 1A evidence with no survival benefit, and I'm confident you don't use it in your hospital system. And of course, that's not true because vasopressin has utility and is a valuable tool in the toolbox for us. It has a narrow therapeutic window, and I have a bullet point here which says that it cannot be titrated. That's not entirely true, but I think the vast majority of people do not titrate it because of the issues of potential toxicity. And we know that the toxicity is non-trivial. This is the product insert or the label for the drug in the US, and we know that vasopressin can cause impaired cardiac response and can worsen cardiac output. So increasing the dose of vasopressin in patients is dangerous. This is in the label. And we also know that high doses, it can cause mesenteric ischemia, right-sided heart failure, atrial fibrillation, MI, it can cause acute kidney injury, and we know it can cause distal limb ischemia. So we know vasopressin has real toxicity, and we know at lower doses it's probably safe-ish, but it doesn't take away the potential for these toxicities. So, I think that one of the things which is very interesting about vasopressin, I think has struck me for a very, very long time, is that the variable response rate. So if you had asked me prior to the publication of this trial and said, Mink, what is your experience with vasopressin? I would have said, in about 1/3 of patients, it works really, really well. And in another third of patients, it's, meh. And it kind of does a little bit, not very much. And in a third of patients, it does absolutely nothing. So this is a paper that's out of the Cleveland Clinic that was published this year. And in nearly 1,000 patients, they looked at patients who received vasopressin. What they found is only 45% of patients had any kind of blood pressure response. So less than half have a blood pressure response. And I think that that's pretty consistent, at least with my clinical practice. I think this is something which I think is probably likely with your clinical practice, that these patients, sometimes you get an effect and sometimes you don't get an effect. We don't really know why this is the case. So if you look at the VAST trial, they were patients who essentially had a brisk response and didn't. And if you look at the baseline levels of vasopressin, what you find is that most of them had low levels. And this is in the figure in the supplement from the VAST trial. So from a purely hormonal standpoint, most of those patients were relatively low in the range of vasopressin, but we still know that there's variability in sensitivity. So if you had a patient who came out of the operating room after a CABG and their index is 1.8, and you decided to give them dobutamine, and their heart rate went from 95 to 135, and the index went from 1.8 to 1.8, I would argue that almost all of us would stop the dobutamine. However, when you add vasopressin to a patient and there's no response, how many of you stop the vasopressin? I would argue that none of us do. I don't. I think it's insane behavior. I admit to doing it. You're desperate. You have nothing else. The noradrenaline's going up. And you think to yourself, I added vasopressin. Maybe it's helping. It didn't do very much, but I'm just going to keep it on. This is not that thoughtful, but we all do it. And I think it speaks to the desperation factor. So if you look at this in aggregate, what we have, and I would say ARDSNet aside, in critical care is we have 35 years of negative studies. Nothing works. Nothing has been shown durably to improve an outcome in anything. I mean, if that's the case, why go to work? Just send in the robot. But interestingly, despite 35 years of negative studies, the outcomes continue to improve. This is the Australia-New Zealand data published in JAMA 2014, and what you're looking at here is adjusted for a long list of appropriate covariates, and what you see is that the survival, the mortality in severe sepsis is going down from 35% to under 20% in about a decade. That's impressive. This is not just down under. This is the North American data. So despite all this negative data and all this negativity, and I would argue nihilism, I mean, it takes no special genius to come onto rounds in the morning and see a patient on very high dose vasopressors and say, has anyone spoken to the family? Is palliative care involved? I mean, if that's what you do on service, you probably need a different job, because that's not helping anybody. Anybody can do that. In fact, I would argue you're in the wrong business. If your approach to severe septic shock after the fluids are in and the antibiotics are in is, well, we've done everything we can, let's see what happens, this is the best we can do. I mean, you should have gone to the clergy, because they can do that. They come by and say, hey, it's up to God. So if you don't think what you do matters, you should get a new job. Because what these data demonstrate to me is that the outcomes are getting better. And the outcomes are getting better, in my view, because of a construct of compounding of interest. So there's this notion of the accumulation of multimodal advancement. And what that basically means in simplistic way is that over time, we have seen improvement. And what I think is happening is you take these 1 or 2% improvements, and over time, they begin to improve and they compound, like compounding of interest and improvement. And let's look at some of these things. Inhaled nitric oxide. This is an expensive therapy in America. I don't want to take care of a patient with RV failure without this tool in my toolbox. Prone positioning. Cochrane Review says there is no benefit, no survival benefit. Some trials say yes, some trials say no. ECMO. We have two randomized controlled trials in Europe. In the New England Journal, no survival benefit. This therapy costs between $50,000 and $100,000 a day. Does anyone here want to stop using ECMO? Bedside ultrasound. Has anyone ever seen a paper that demonstrates in a randomized controlled trial this actually alters outcomes? I haven't, but I never want to put in an IJ catheter or a Quinton into someone's neck who's fully anticoagulated without ultrasound. And even CRT. This is an expensive therapy. Who wants to take 2.5 liters off an intermittent hemo in 2.5 hours in a highly shocked patient? All these things come together. And when you string these things together, you get accretive improvement. These interventions accrue over time to improve outcomes. And that's why, despite 35 years of negative studies, we have gained insights, whether it's better sugar control, bedside ultrasound, CRT, catecholamine sparing, low tidal volume. You add these things together, you string them together, the benefits compound. So therein lies how we arrived at the Athos 3 study design. So the primary efficacy endpoint was mean arterial pressure. We did not go for or try to hit survival. And this was highly intentional. And there's a reason for this. Because what happens most of the time when you get an endpoint, which is survival, which is very hard to hit, you become enamored with your drug. So you're a big drug company, you license a new technology from an investigator at a big university, and you say, hey, this thing looks great, we want to take it. You go to FDA or the EMA and they say, oh, you got to show us 30-day all-cause survival benefit. And you say, that's going to be really hard. We really need a dramatic effect size to take such a severe disease and improve the outcome. And because you have spent the time and money, you fall in love with your drug. And because you fall in love with your drug, you then conclude that more must be better. So the idea is that I'm going to shove as much of this drug down this patient into their throat as I possibly can. Because the idea is the more drug I give them, the better they're going to do. And when you do this, it causes a separate series of problems. And this is because when you push harder and you give more drug, you fail to remember one of the obvious first teachings of medicine, which is that all drugs have toxicity. All drugs have toxicity. So when you push the dose up, and that's what most of these large registration trials do, they push the dose as high as they can, they end up in a different place. So all drugs have their therapeutic effect if they're a good drug. And ideally, at the maximum therapeutic effect, there's very little toxicity. But as you get to the higher therapeutic dose, you enter into the area of toxicity. And this is your therapeutic index. And obviously, you want to stay onto the left side, closer to the blue line. But you're a drug company. You have a lot of money riding on this trial. So what are you going to do? You're going to push the dose. And when you do that, you push the dose largely into the toxic range. As a consequence of this behavior, most drug trials push the dose, and instead of sitting in the sweet spot, you push yourself in the toxic range, and then you corrode. You undermine the benefit. And so we said that we want to move to this place, which is here. We want to keep the drug dose range in the therapeutic effect. And when you're titrating to mean arterial pressure and you're pushing for a clinically relevant endpoint, you don't feel the need to get out way over here. So the goal isn't give the patient as much angiotensin II as they can tolerate and push all the other drugs away. The goal was give angiotensin II, leverage multimode therapy, decrease toxicity, and demonstrate safety first with a clinically relevant endpoint, which is how we arrived at the ATHOS-3 study design. And so, in America, I know this is a talk intended for a UK audience, so I apologize. So this should have been probably a cricket slide. But what you're looking at here is a series of baseball players. And if you look at this list of baseball players, most Americans who know anything about baseball would probably say this is a list of home run hitters. But in fact, this is the strikeout leaderboard. I guess the cricket analogy would be the reason you don't go for a 6 all the time is because it's more easy to be caught out. And that's why it is safer and more thoughtful to go for a straight drive and a boundary and keep up your run rate. That was the goal of the trial. The goal of the trial was to get on base. And so the person who we look up to is Ted Williams, who has the highest on-base percentage in the history of American baseball. The idea is show a clinically relevant endpoint that's safe, get on base, get the drug approved, and from there we can then build thoughtfully on where the drug can actually show really durable survival benefits. And, this all really started with a pilot trial that I conducted and published in 2014 with my group at GW. And in this pilot trial, which was basically just 10 patients on drug versus 10 patients placebo in a randomized controlled fashion that was blinded, one of the main findings of the study was that 2 patients were exquisitely sensitive to angiotensin II. Now, at the time, it was my view that the likelihood that this was happening, the likely reason that this was happening is because these patients have been taking ACE inhibitors before they got sick. And it seemed like a good hypothesis. The 2 patients who were exquisitely sensitive, and just so you understand what I mean by exquisitely sensitive, these are patients who are on 20 to 25 mics per minute of norepinephrine and vasopressin. They get the angiotensin II or placebo. In this case, I didn't know, but I may be blinded, but I wasn't stupid. The blood pressure, the MAP goes from 65 to 100. We titrate off the norepinephrine and the vasopressin to off, and the patients remain hypertensive on the lowest dose of angiotensin II. And this spoke to deficiency to me. So, based on these 2 patients having this exquisite sensitivity, we thought they'd been taking ACE inhibitors. And we sent this paper into critical care, and we said these patients probably have been taking ACE inhibitors. And the reviewer from critical care, who apparently is a Tottenham Spurs fan, attacked us and said, yeah, that's really nice, but were they or were they not on an ACE inhibitor? So we went back, we looked very carefully, we couldn't find it, and we went back to the reviewer and said, hey, we can't find it, but we're pretty confident they were on an ACE inhibitor. And then we went through another round of reviews, and the reviewer said, were they or were they not on an ACE inhibitor? So then we did this enormously deep dive. We went into the medical records, we went back to pharmacies, and to our surprise, we could not find the ACE inhibitor. And so we wrote in the discussion that it could be an ACE inhibitor, but we can't find the documentation. This really created a huge quandary for us. And the reason why I'm going after this reviewer is because it was Louis. And Louis was a reviewer for critical care. We weren't friends then, and he's a Spurs fan, and I'm an Arsenal fan, so this remains a problem for us. But nonetheless, this was an important thing that Louis did because it forced us to look elsewhere. And I'm a little embarrassed to say it because it took 6 to 9 months to actually solve this, and it really wasn't that complicated. But it turns out that ACE, angiotensin converting enzyme, is primarily a pulmonary capillary endothelial ectoenzyme. And what that means is that this enzyme doesn't do its business by being in the bloodstream, by being in the plasma as a circulating enzyme. It sits on the endothelium of the lung and it does its angiotensin converting enzyme business from the platform of the pulmonary capillary endothelium. And so then we asked ourselves the question, well, what disease could cause sufficient pulmonary endothelial injury that might cause an ACE defect to justify why patients may have an angiotensin II deficiency. And of course, that disease is ARDS. And we went back in both the patients who were exquisitely sensitive, both at ARDS. And so then I thought to myself, no one's going to believe this. So we should go and design a study where we take an angiotensin converting enzyme, gold standard substrate, and give it to patients with varying severity of ARDS and demonstrate that in ARDS, the severity is linked to this lack of conversion. And when we went to go design this trial, we found this paper that was published in a very obscure journal called Circulation, published in 2000. And this study has already been done. So in 2000, this group took this ACE substrate, BiPAP, which is a ACE gold standard substrate. And what they demonstrate quite beautifully is that this is lung injury score. This is the old Murray lung injury score, which is similar to the Berlin criteria. I actually think the Murray lung injury score is better because it actually assesses how much PEEP you're on. But whatever, I'm an old fart these days. And what you see is that as your lung injury score goes up, your ability to convert angiotensin I to angiotensin II is undermined. And so it led us to this hypothesis. We sent this back into critical care to try and get this concept down correctly, which is as follows. Whatever your inflammatory insult is, whether it's a cardiac surgeon or whether it's bypass or whether it's pneumonia, whatever it happens to be that's given you this event, if you have a severe insult and it leads to ARDS with endothelial injury, this can lead to a loss of pulmonary capillary endothelial ACE activity. And if you lose that ACE activity, you will get an angiotensin II insufficiency. And if you don't have angiotensin II around, you're not going to have much GFR, and you actually become catecholamine resistant. And so these patients are at high risk for AKI and catecholamine resistance. And we think this is what explained those two exquisitely sensitive patients in the trial. And it was a group of patients we were looking at very carefully in the ATHOS-3 trial. And so just to give you an overview of the study, what typically happens when people look at ATHOS is they complain and say something like, I don't know how this got into the New England Journal of Medicine. So if you go to a journal club at a non-specified U.S. hospital and listen in on the fellow presenting ATHOS-3, the general view is that the fellow will say, well, I don't understand why Drazen and the New England Journal took this paper. This doesn't make any sense to me. Everyone knows angiotensin II is a vasopressor. Everyone knows that it raises blood pressure. And all they did in this trial was raise the blood pressure from 65 to 75. And I don't use 75 as my MAP target, so this doesn't help me at all. And then the attendings then begin to question the fellows on a bunch of statistical tests that they've never heard of or don't recall or don't know what they mean. What's the Fisher-Exak test? What's the Kolmogorov? What's the median interquartile range versus mean? Why do you use which one or the other? And then journal club is over and everyone walks out of the room. And that happens all over the world, I would imagine, and not just in the US. But I think it fails to recognize the rationale for the paper in the first place. So when we sat down with FDA to design this study, they initially requested a 30-day all-cause survival. And we said, this is a vasopressor. This is not an antiseptic drug. This is not a host response drug like Xigris. This is not an antibiotic. This is not an IL-1 monoclonal antibody. This drug is designed to raise blood pressure, so we think you should use other vasopressors as the precedent. And they said, well, we don't really think so, and this is something which you guys really need to work on as a survival endpoint. And then we said that, but if you look at all the antihypertensives, they're all approved based on blood pressure. They're not approved based on major adverse cardiovascular events. They're based on blood pressure. So we asked them, when you guys approved nicardipine, where's the 30-day, 28-day MACE outcome? The primary efficacy endpoint for nicardipine use and approval in the US and Europe is a blood pressure endpoint. And if you think that short-term management of hypertension is important, well, we would argue quite strongly that if you're on noradrenaline and you're on vasopressin and you're still hypotensive, hypotension is much more dangerous for you than hypertension. And they agreed. And so then we set out to develop an efficacy endpoint. And what we said to them is, they said, well, what do you guys propose? And we said, well, we'd like to show you that in patients on high-dose catecholamines, that we can cause a 50% reduction in catecholamine dose in 3 hours. And they disagreed. They said, look, your drug is a vasopressor. You're saying that it has effect on blood pressure. So if you want to show it's a blood pressure drug, you have to show a blood pressure endpoint. Catecholamine sparing is not a blood pressure endpoint, although we understand the rationale for why you're proposing it. And so we said, okay, what do you propose? And one of the proposals was, well, in hypertension, what we do is we take patients, we allow them to come out of control. Their blood pressure is 140/90. It goes up to 200/100. And then we add the new drug and we bring them back into control. And so maybe you could take patients who have a MAP of 65 or 75 and let them drift down to 45 or 50 and then rescue them with angiotensin II. And I think that makes sense from an intellectual standpoint, but it's quite clear that that's not a study that most intensivists would partake in. It's probably quite dangerous, and it's just not a feasible study. So we agreed that the sepsis PAM data from Asfar and colleagues published in the New England Journal demonstrated that there's no harm in taking a patient from a MAP of 65 to 75 who's got vasodilatory shock. So we agreed that in order to demonstrate that angiotensin II is a safe and effective vasopressor, we would take patients and we would increase their MAP from 65 to 75 for 3 hours, thus demonstrating with all the other vasopressors being held stable versus placebo, we can raise blood pressure in an environment of refractory shock. And then from hour 3 to hour 48, we would demonstrate catecholamine sparing, which is a clinically relevant endpoint. And that is how Athos 3 was developed. And I think all of us who worked on Athos 3 recognize that this trial is not a very good marketing trial. This is not a good study to go out and commercialize a drug and show everyone we're better than somebody else. But this is the study because it is placebo-controlled. And while I know most people would have preferred us to do a comparative efficacy trial versus vasopressin or noradrenaline, recognize that in order to get a drug approved, the highest form of evidence is a placebo-control because it allows the best assessment of safety. And this is a study that we did. So we did a randomized controlled trial, placebo-controlled, demonstrating a blood pressure effect, catecholamine sparing, and importantly, safety. And that's the trial that was published in the New England Journal. We randomized 344 patients. And I'm confident most people listening to this talk have seen this paper and read it, and then probably got quizzed on a bunch of statistical tests that they didn't know what they were. And in any case, the primary efficacy endpoint was this first 3 hours to show the blood pressure effect and then catecholamine sparing. And the effect on blood pressure is dramatic. This shows you what happens over the first 3 hours, but this effect typically happens in about 5 minutes. And so we know that angiotensin II gives you a robust blood pressure effect. And I don't think people are terribly surprised by this, but this is what we needed to do to demonstrate the safety and efficacy for the FDA. Now, what you're looking at here is the Kaplan-Meier curve for the trial. As I mentioned previously, the study was not powered for survival, but we were delighted to see a very nice survival trend line in favor of angiotensin II. The separation occurs quite early, which is gratifying, and the p-value is 0.13. And the trend line is there. And the New England Journal said, well, you guys have a little bit of an imbalance in age and gender, so we'd like you to do that as an adjusted analysis. And when we did that, and this is in the supplement of the trial, the p-value for this actually becomes statistically significant with this continued early separation in survival curves. And I think one of the things that pleased me enormously about this trial was the fact that if you look at the serious adverse events, and this is placebo here, 67% versus 60% angiotensin II, patients getting angiotensin II had fewer serious adverse events than placebo patients. And this is not because saline is so terrible for you, although I think that saline is probably bad for many people, and there's many a saltwater drowning in an ICU around the world in North America and Western Europe. But the main reason why we think Ang2 is associated with fewer serious adverse events is because it allows you to unload toxic doses of catecholamines. And when you unload those toxic doses of catecholamines, it leads to better safety. And this is something which heartened us because all drugs in the ICU that we give were associated with having toxicity. So this was a very nice result that we were pleased with. I think it's important to recognize that in the trial, there was a difference in patients with DVT. So in the Athos publication, if you look at serious adverse events, it was 3 versus 0. If you include minor DVTs, upper extremity, central lines being clotted, it goes to 7 to 0. And the FDA did their own analysis wherein they used a series of terms which they qualified into any thromboembolic event. They basically showed an asymmetry of 12.9% versus 5.1%. And this is the specific data. What you're looking at here is grade 1 and 2, 3, and 4 events. And basically grade 1 and grade 2 are less severe. Grade 3 and 4 typically live in the serious adverse event range. And what you can see is that the FDA utilized this term of any thromboembolic event, which included stress cardiomyopathy, thrombophlebitis, device occlusion. And what you see is that there is an imbalance, and most of these events occurred in the lower grade events. And most of these events occurred in patients who were not taking their VTE prophylaxis. And so in our label, it says that patients should be receiving VTE prophylaxis before getting angiotensin II. And I think that's appropriate. Now, I think that the issue that we have been asking ourselves is there a mechanistic link between angiotensin II and thrombosis? And the answer is that there's nothing obvious about why they would be linked, but I think it's important that we do look at this carefully, and we have ongoing pharmacovigilance and safety for this. You know, this talk is being recorded in November of 2018. Angiotensin II has been available in the U.S. market for about 9 to 10 months, and we have not had any DVTs or arterial thromboses reported into our pharmacovigilance safety as of today. And so that is a piece of good news, which makes us feel good that we continue to have a very good safety profile. That said, just because things haven't been reported doesn't mean it hasn't occurred. And I still think it's very important that patients be on VTE prophylaxis if they're getting angiotensin II. I think if a patient has a previous history of thrombosis, to have an abundance of caution, that's probably a patient you want to avoid giving angiotensin II to. So the summary is that patients with receiving angiotensin II, it safely increases blood pressure, which is really not surprising, but had never been demonstrated with this level of evidence in a modern era with modern safety reporting. And this is what led to the approval in the U.S. And I want to just take a moment to refresh your memory on something which you all know. Everyone here is aware of the fact that angiotensinogen, which is produced in the liver, is then converted to Ang1, and then through lung and actually renal endothelial ACE is converted to angiotensin II. And this was the reason why we thought we saw those exquisitely sensitive patients in the pilot trial. And so in order to assess this in the trial, because ACE in the blood is not a great way to measure ACE effect, so we decided to look at the angiotensin I and angiotensin II ratio. And the idea here is that if you know the substrate and the enzyme in between and its product, you can approximate the functionality of ACE by looking at the angiotensin I to angiotensin II ratio. And so what you're looking at here is this is a pre-specified analysis looking at the survival of patients based on the ratio. So 1.6 is the median. Now, all of you listening to this talk have a ratio of around 0.5. So one of the first things that's important to recognize is that patients with vasodilatory shock in this trial have highly disordered ACE dysfunction because the Ang1 to Ang2 ratio is quite high. The Ang1 is building up. But what you notice here is that if you're closer to normal, so 0.5 is normal, you don't really have a survival benefit. The curves are quite superimposed. But if you have significant ACE defect as measured by a higher Ang1 to Ang2 ratio, what you see here is a statistically significant survival benefit in a pre-specified analysis. And I would like you to note the early separation in the survival curve. So this speaks to the notion that if you have significant angiotensin converting enzyme defect, angiotensin II is associated with a survival benefit. And this was a pre-specified analysis because we thought this might be a way to drill down to this group of patients who gained benefit. Now, one of the things which was really interesting is that, not surprisingly, in the study, patients who were in the angiotensin II arm who received exogenous angiotensin II, their levels went up. What you're looking at here is the angiotensin I ratio, Ang1, not Ang2 now, and you're looking at it from baseline to hour 3. And what you see here is that the angiotensin I level drops dramatically in 3 hours in the patients who received LJPC 501, which is exogenous angiotensin II. So giving angiotensin II resulted in this very large drop in angiotensin I levels. The p-value for this is less than 0.001. So, we were initially quite struck with this. And why would the angiotensin I levels drop so fast in only the group of patients who got Ang2? You can see the placebo patients, the Ang1 levels completely flat. So, my team asked me, and I said, I think this is probably biofeedback. If you have a patient who has a very high TSH, because they don't make T4, and if you give them T4, the TSH goes down back through biofeedback in the endocrine system. And so, similarly, I think that what's happening here in these patients is that you have endothelial injury, you have an ACE defect, and so your ATR1 receptor is not being engaged, and the biofeedback tells the body, I'm not getting enough ATR1 receptor, so you make more renin, you produce more angiotensinogen, the angiotensin I levels build up. Now, if you then give exogenous angiotensin II and you engage the ATR1 receptor, this then works in reverse, and the body decreases renin production, decreases angiotensinogen, angiotensin I levels go down. And I think that this made sense and this was rational, and it was sort of an interesting finding. And then Steve Chen, who works with me here at La Jolla, asked me a pretty interesting question. He said, Mink, can angiotensin I be bad for you? And I thought that was a really important question because I don't know of anything that angiotensin I does that's bad, but there are a lot of other angiotensins. It's not just angiotensin I and II. There's a whole host of other angiotensins that are quite vasoactive. And so we just published this data in Critical Care. This came out a few weeks ago. And what we basically show is that this is what everyone has been taught in medical school. Angiotensinogen through renin goes to Ang1, then to Ang2, and it gets converted by ACE. But there are other angiotensins like angiotensin I to 7. Now, angiotensin I to 7 is really interesting because angiotensin I to 7 is one amino acid different than angiotensin II. But it has the complete opposite effect. It's a vasodilatory, vasodepressive, and it does the exact opposite. And there are all these other angiotensins and other things that are linked. And so what we think is happening in vasodilatory shock is that you have an angiotensin converting enzyme defect due to endothelial injury. And when you have this ACE defect, it results in an accrual of vasodilatory peptides like bradykinin, angiotensin I, angiotensin I to 9, and angiotensin I to 7. So, in essence, when you have significant endothelial injury, and recognize that endothelial injury is a core feature of the septic shock syndrome and vasodilatory shock syndrome when it's inflammatory, you have a dual defect. Not only do you have an angiotensin II potentially insufficiency or deficiency, but you have an excess of these vasodilatory angiotensins. And so, this is not some random idea that we've come up with. Angiotensin I to 7 is an effective vasodilator. In fact, it's such an effective vasodilator, there are drug companies working on angiotensin I to 7 as an antihypertensive therapeutic. This is a trial of patients who are on captopril, and they looked at the predictors of improvement in blood pressure. And what they found is one of the strongest predictors of an improvement in diastolic blood pressure in hypertensive patients receiving an ACE inhibitor is their angiotensin I to 7 level. As their Ang 1 to 7 level goes up, the diastolic blood pressure goes down. So it's been well established for quite some time that this is an important angiotensin with vasoactive properties. And I think a really good example of this, and this study, when I looked at it, really struck me. We're classically told that half of what you learn in medical school is wrong. You don't know what half. And I think here's a very good example of this. This is published in 1996. And what you see here is the baseline angiotensin 1 to angiotensin 2 levels in a patient who is an essential hypertensive prior to their first dose of an ACE inhibitor, in this case captopril. Now, they take their captopril and then they measure their angiotensin 1 to angiotensin 2 ratio. And every single one of us is taught that when you take an ACE inhibitor, the reason why your blood pressure goes down is because your angiotensin 2 levels go down, except for the fact that it doesn't. The angiotensin 2 level, pre and post captopril, is nearly identical. Look at this. But what does go up is your angiotensin 1 level. Now, 6 months later, this is your pre-captopril dose. It looks nearly identical to your post-initial captopril dose. And what you see here is your angiotensin 2 level is largely unchanged. Now you take your captopril dose, and what you can see is the angiotensin 1 level is 50-fold higher after 6 months post-captopril dose than the day they started. And your angiotensin 2 level is unchanged. And what this means is that, by and large, the effects of ACE inhibitors, the vasodilatory, vasodepressive effects that improve outcomes, is not about Ang2 drop in the blood anyway. There might be levels in the tissue that are important, but in the bloodstream, it's about these other angiotensins rising. And so what we think is happening in this subset of patients who have the high Ang1 to Ang2 ratios as follows. You give them angiotensin 2, you engage the ATR1 receptor, and that gives you some blood pressure effect, but it also gives you biofeedback. And now the impetus, the drive to make angiotensinogen and renin goes down. This results in less angiotensin 1, and we've shown that now in this paper, in the Athos trial, that the angiotensin 1 level goes down dramatically in 3 hours when you get angiotensin 2. And then we believe what this does is it decreases your 1 to 9 levels and your 1 to 7 levels. And so these other angiotensins, these vasodepressive active peptides, then begin to diminish as well. And as these are all ACE substrates, what happens is your ACE availability increases because it doesn't have as much substrate to have to remove. And if your ACE availability increases, your ability to take down bradykinin probably goes up as well, and this goes down. So what we think is happening in these patients who are exquisitely sensitive is a dual defect. An amelioration of vasodilatory angiotensins and bradykinin in addition to the improvement in angiotensin 2. And it looks something like this. You have this, for lack of a better word, angiotensin detritus. These vasodilatory things floating around, and it gives you this imbalance. And when you give angiotensin 2, you put your thumb back on the scale and you restore some harmony by getting some robust blood pressure effects from the ATR1 receptor, in addition to the removal of some of these other vasodilatory, vasodepressive angiotensins. And if this were true, what you'd expect to see is that in patients who have this defect, they're more likely to have acute kidney injury, severe acute kidney injury, and you'd expect GFR to be restored in those patients because their Ang2 ratios are lowish. They have these high Ang1 levels, 1 to 7 levels. And so we looked at this in patients who had acute kidney injury requiring renal replacement therapy. So all these patients, these are not end-stage patients. I repeat, these are not end-stage patients. This was published in Critical Care Medicine in 2018. In this study, we looked at the patients who had acute kidney injury requiring renal replacement therapy. So they all have KDIGO stage 3. And these patients have some of the highest angiotensin 1 to angiotensin 2 ratios in the entire cohort. And what we find is that these patients enjoy a highly statistically significant survival benefit. The p-value is 0.01. And notice again the early separation in survival. And I think that, well, this was very nice, of course, and we were pleased to see this result, but what was much more gratifying was to see the renal replacement recovery rate. So all patients start on renal replacement therapy. So 0 have discontinued at the beginning of the study. And then what you see is that in the placebo arm, over 7 days, 18% of patients recover and come off renal replacement therapy in 7 days. In the angiotensin II arm, that number is 38%. And the p-value is 0.007. It's highly statistically significant, and it holds up in multivariate analysis. And so we think that this is potentially a really important finding because it's mechanistically linked. It demonstrates an enormous value proposition because renal replacement therapy is very expensive. Having a survivor survive and be a dialysis patient is expensive to society and very expensive to that patient's quality of life. And so this may be a really important way that we can demonstrate where the value proposition of angiotensin II lives. And I think that what's interesting about this is that even though this is a post hoc analysis, and we must be open about that, is the fact that this is highly mechanistically linked. And this is obviously an area that we can hope to continue to work with and look at. So in essence, the basic summary of this is angiotensin II is an excellent vasopressor with a good safety profile. But for some patients, it's not just another vasopressor. It's the missing vasopressor. It's the missing vasopressor. And when it's the missing vasopressor, we see dramatic impacts that are linked to improved morbidity and mortality. So I just want to show you a few cases that have been published in the literature. This is a 70-year-old gentleman who had colon cancer, went to the operating room after a perforated viscus, and came out very sick, had received a lot of fluid, and was on high-dose vasopressors, and they utilized angiotensin II to rescue this patient. So just to orient you to the slide, up here in red is the norepinephrine dose, and in blue here is the vasopressin dose. So you can see down here the patient goes to the operating room, they come out, and they get placed on Zosyn when they come out, because everyone gets placed on Zosyn in the ICU. And then they decided that they put them on Zosyn, but they forgot the vancomycin, which is over here. And I think that the utilization of vancomycin and Zosyn is so common in ICU, we should just add it to the saline and make it the ICU drug and do it as a continuous infusion, because then no one will have to think about anything ever again. But what you see is the norepinephrine dose, and this is the vasopressin dose. And what you see here is the patient then comes out, they're in the ICU, they get their vancomycin, they get the obligatory voodoo of methylene blue, which has no impact on the norepinephrine dose or the vasopressin dose. They add meropenem, because why not? Because Zosyn's not enough. And then they add B12. Now, I don't think this is a very big thing in Europe, but in America, we use a lot of B12 as a voodoo technique for refractory shock. And this is based on a single case report that was published, I think, Annals of Thoracic Surgery, I want to say, for vasoplegia. And I always found this to be a little bit bizarre because I don't think pernicious anemia is the problem we're dealing with in shock. But nonetheless, they tried it anyway. Nothing happened. This patient continues to be on high-dose noradrenaline, and then they add angiotensin II, and what you can see is an immediate drop-off in the norepinephrine dose, followed by a drop-off in the vasopressin dose, and this patient did very well and actually survived. And what you can see here is the moving average for MAP. This is in blue. The blood pressure comes up nicely. The heart rate comes down. The stroke volume improves. The SVV comes down, and the SVR comes up. And this is what you would expect to see when you give a patient a vasopressor. And I think in this patient's case, looking at the clinical course, they behave as if that this was a patient who was angiotensin II either deficient or sensitive, and I think it's hard to know because we don't have those levels measured in this patient. And here's a case of vasoplegia. This is where we see an enormous amount of use of angiotensin II since approval. is, in a patient who has been taking an ACE inhibitor or an ARB and then goes to the operating room and you bypass the lung where you convert Ang1 to Ang2, it makes sense that these patients might be sensitive. This is a patient who had a low EF, came out very hypotensive, very similar case. And just to orient you, this is a patient where the bypass starts. They come off of bypass. You can see they're on high-dose norepinephrine, and they get the obligatory methylene blue and vasopressin, and there's really no improvement in blood pressure. They add angiotensin II here, and what you see is then the norepinephrine dose begins to come down right away, and they also have a drop-off in the epinephrine dose as well. Later on in the patient's course, they get their obligatory B12 with no change in either the norepinephrine dose or epinephrine dose. But importantly, this patient goes on to get extubated within 24 hours to meet their STS criteria. And so in the U.S., when we get graded on being able to achieve certain endpoints, being able to use a novel vasopressor like this to help these patients get there better has been a nice tool in the toolbox. And I think another important point, and this question has come up very frequently, is does angiotensin II cause increases in the pulmonary arterial system? And what you see here is that this is when the angiotensin II was started. This patient actually had a PA catheter in, and what you see here are the PA pressures, and the CVPs are largely unchanged. The healthy volunteer data that's been published with bovine angiotensin from many, many years ago shows some variability of the effects of angiotensin II, but clinically, in patients who are shocked, we tend to see this type of PA pressure type of movement, which is that it's largely flat. It's not a pulmonary vasodilator at all, by any means, based on any data that we see, but it also does not cause what appears to be any significant pulmonary vasoconstriction. And I think one of the areas in which we do need to do more work is to get some better granularity around this to be able to demonstrate to the community what the hemodynamic effects are, not just in the PA, but PVR, cardiac output, inotropy, et cetera. Now, I want to take you back to this paper that was published by the Cleveland Clinic Group because I think it's really important. And I think one of the findings of this study, which I showed you earlier, is that when patients get vasopressin, less than half respond. And I think that's largely consistent with my clinical experience. But what's very interesting is that if you respond, you have a much better outcome. So if you are a vasopressin responder, which means any improvement in MAP or decrease in catecholamine dose in this cohort, your mortality is 57%. But if you don't respond, your mortality is 72%. And this is highly statistically significant. And I think that if we discuss this in an abstract way, I think we would all agree that it makes sense that not all patients respond to all vasopressors in the same way. Some patients are more sensitive to norepinephrine, some patients are more sensitive to vasopressin, and some patients are more sensitive to angiotensin II. And not surprisingly, if you're sensitive to the vasopressor, you get a better outcome. Now, we don't measure this well with norepinephrine because it tends to be our first-line therapy. But this clearly shows to me that vasopressin sensitivity alters outcomes. And the same is true for angiotensin II. So this is what angiotensin II responders look like versus non-responders. If you are an angiotensin II responder, what that means is that when we give you angiotensin II, you enjoy this very robust blood pressure increase, which occurs in around 70% of patients in the Athos 3 trial. What you find is their survival is 70%. But if you're resistant, your survival is 30%. And look at the separation. Look at the immediate death level if you are resistant to your vasopressors, because many of these patients were getting angiotensin II added after vasopressin. If you are resistant to all of your body's endogenous vasopressors when they're given exogenously, you're going to die. But if you're sensitive, you live. And so this, to me, is very similar to the way we think about antibiotics and sensitivities to organisms. Time to the sensitive drug improves outcome. And so if you look at your current guidance for surviving sepsis, it's very clear. You start with a lactate and you get blood cultures. Well, why do you get a blood culture? Well, you get a blood culture because you want to make sure that you know what organism you have so that you're not compelled to keep them on 4 antibiotics. Because the next step in surviving sepsis, the management of septic shock, is to administer broad-spectrum antibiotics. And then you give them some fluid, then you give them a vasopressor, and then you de-escalate your antibiotic once you're done. Well, I think that in the future, now I want you to imagine a time and place where all these drugs are cheap. So this is not today. Let's be very clear. This is not today. But all the drugs are cheap. So there's no fighting about your drug is expensive, this one's less expensive, so use this one first. So the pharmacy is not blocking you from doing what you want to do, which is common, especially in the US. I think your 1-hour bundle is going to look something like this. You get your lactate, you get your blood cultures, you get started on broad-spectrum antibiotics, then you get your fluid. And if you get your fluids and you're still hypotensive, the next thing that we will get from you is a vasopressor sensitivity panel. And then we will start you on broad-spectrum vasopressors. Broad-spectrum vasopressors. Why? Well, time to a sensitive drug is almost certainly going to be associated with a better outcome. If you're failing norepinephrine and you're failing another drug and you're vasopressin sensitive, why are you waiting to give it? If you are deficient in angiotensin II, why are you waiting to give it? This does not make sense. Now, I recognize that in the modern age, where we are right now, cost matters, money matters, we have to be thoughtful. But in the future, this is now in the future, 20, 25 years in the future, you will get broad-spectrum antibiotics. You will get broad-spectrum vasopressors. You will start all 3 at once. It may go in the same vial. It may be in the same bag. And then you would de-escalate the vasopressor and the antibiotics much in the way we de-escalate antibiotics based on sensitivities. Now, I think that, as I mentioned before, we're at the point where there are significant cost constraints. And in the U.S., the course of therapy of vasopressin, which is usually 5 to 6 days, it's a roughly $450 a day, is about the same cost as 2 days of angiotensin II, which is roughly the same cost. And so, there's a lot of people saying, well, look, on a per vial per day dose, angiotensin II is just too expensive for us. And I get that. I mean, it is on a per daily basis. If you did it in just that narrow lens, more expensive. And if you look at that from a pharmacy standpoint, this becomes a real cost concern. But the course of therapy, because vasopressin tends to stay on for 5 to 6 days, is the same as angiotensin II, because the course of therapy is 2 days. And so what I have been telling people is that if you get vasopressin and you're vasopressin sensitive, that's great. And I don't think you should be waiting until you're on 0.4, 0.5, 0.6 of norepinephrine to figure out if you're vasopressin sensitive. What I'd prefer people do is at 0.1 or 0.2 of norepinephrine, give a 1-hour test dose of vasopressin. Because if you're vasopressin sensitive, why are you waiting to start it? Because it's going to improve your outcome. If you're resistant, then if you don't have a response to vasopressin, stop it. If it's not giving you the blood pressure effect, because you're not giving the vasopressin for a survival benefit, VAS and Vanish have disabused us of that notion, why not give a vasopressor to which the patient might be sensitive? That, to me, is a financially thoughtful way to use angiotensin II. Use it in patients who are vasopressin resistant, which is half the patients. This is not our data, this is the Cleveland Clinic data. If they don't respond to angiotensin II, similarly, you should stop it. But if they're angiotensin II sensitive, they're going to enjoy a survival benefit. Time to the correct sensitive drug matters, right? That's one of the fundamental teachings of critical care. So in summary, and the way to think about this is that, if you're running around and you bump your knee and your knee hurts and you're taking Tylenol and it still hurts, do you continue to take Tylenol or do you switch to Motrin? or ibuprofen? I would say that almost all of us switch, but not in the ICU. We add epinephrine to norepinephrine, which is the same drug when you look at the metabolism, and then we add vasopressin, and then we add back more catecholamines. This is deeply anti-intellectual behavior. And then if they don't respond to vasopressin, there's no response at all, we keep it going. And so I think if we want to start with improving outcomes, and this is aside of angiotensin II, I think we have to stop doing things that don't make sense, at least physiologic sense. And I would say in summary, all our trials are negative. And despite that, we have improved outcomes. And this is because all these things we've learned over time, low tidal volume, CRT, fast hugs, DVT prophylaxis, head of bed up, non-catecholamine vasopressors, all these things come together. And when you are thoughtful and you add them together, you get improved outcomes. Currently, we only have 2 non-catecholamine vasopressors available. They both work on different mechanisms of action, and I think that using them together makes a lot of sense because I think it makes sense to leverage synergy. In a cost-austere environment, my proposal would be use the drug for which you get the result that's intended. If the patient is sensitive to that vasopressor, continue it. If they're not responding to it, stop it. Multi-mode therapy is accretive, and I think that this is the future, and we need to continue doing this. And I think this allows for synergy and less toxicity. And I think one of the things that we have demonstrated with the available data is patients who are angiotensin II deficient have this dual defect with the accrual of vasoactive angiotensins, and they get improved outcomes when they get angiotensin II. And I think the best way to identify those patients who are most likely to be angiotensin II and have ACE defect are those who have ARDS, acute kidney injury, and those who've been taking ACE inhibitors prior to becoming ill. But I think that we need to think about vasopressors in the same way we think about antibiotics. Time to the correct medication matters. Time to the correct medication matters. So with that, I will stop, and I hope I didn't bore you to bits. And a little shout out to Louis for being very painful during that initial review of our pilot trial. But I think it led us to a very good place, and very pleased that angiotensin II is available to U.S. clinicians, and we are cautiously optimistic that angiotensin II will be available in Europe in sometime of middle 2019. Thank you very much.